So now in section 4, which is probably I consider the most important decision factors of any given case, is what are my options? If I have a suspect disc herniation cases, what are my options in terms of how to treat that? Generally, we have two options. The medical management, which involves restrict activity and pain medications, or we surgically take out the disc herniation and with procedures, right? And the decision on doing medical management or surgery is largely depends on the clinical gradings that we have, which is highlighted in table 3. And this is really the most important factors, at least for me, to decide one way or the other. So injury severity, we can divide it clinical grading into 5 different stages. Initially, they start with just only the back pain, where they're walking on their own, and they're just having back pains, or they're walking but they're on their own but they're wobbly. So we call it ambulatory paraparesis. PP means the paraparesis. Progress further downgrade to that is they're not walking on their own, but they're still moving their leg. And the further grade down is they're not moving their legs, so we call them paraplegia, but they still maintain the sensation of pain. So we call them deep pain positive. And the very last grading is paraplegia with no pain sensations. And why this clinical grading is very important is because it directly kind of dictates how the outcomes may be. In the first two gradings, medical management about 80% successful. Surgery is the higher success rate, but generally speaking, I consider them high enough that they don't have a strong enough material difference. Once it gets to the point that the dog is non-ambulatory, meaning the dog's not walking on their own, you place it in point A and walk away. The dog is not standing up and walking towards you to point B. This is usually the time the surgery kind of started to become more helpful. Yes, the number wise, 81% versus 93%, it may look similar, but the comments that they have is level of recovery of a non-ambulatory dog was less compared with was less complete with conservative management. And in a further grade down, if the dog becomes totally not able to move but maintain a pain sensation, medical management only gives you about 60% of success rate, and surgery is usually about 93%. So this is usually the time that surgery is starting to become a stronger force of recommending, like this is probably we need to cut it. Once we get to the point that the dog has lost their pain sensations, medical management is really not a great option, whereas surgery usually have about 60% of success rate. So they have concluded that ambulatory dog can be managed successfully medically. However, there is a risk of recurrence, which is highlighted here. Historically speaking, we have seen a recurrence rate somewhere between 15 to 60%. In my personal experience, usually about 25% if we do medical management. So one in every 4 dogs, they may come back because they have like just unresolved pain like years after, or they have like a disc herniation in January and medical manage, and in like November they have another one. So I would say that's my personal experience, but they do have a higher chance of recurrence. But once they get to the point of my dog is non-ambulatory paraplegic, the success rate of recovery, and chance of recurrence are much more likely to improve with surgery. So this is kind of where I generate my own kind of rule of thumb is if the dog is walking, you probably can manage it medically. Just be aware that it can recur. If the dog's not walking, then it probably is the time that surgery will be more helpful. And I found this video to be extremely helpful to understand, right? Because like, okay, you would imagine like walking, not walking should be a pretty clear cut, but they're not always true. So this is a video coming out from the Southeast Veterinary Neurology, a very reputable clinic in the Florida. So they video it in terms of how a ambulatory dog with back pain should look like. So this is a dog that is walking but wobbly, right? So he is following someone, but it's kind of wobbly. Sometimes they also have arching back. Um, Sorry, this is probably the more accurate one. So the dog is attempted to walk towards you, obviously not walking the normal way, but they're trying to stand and trying to walk, right? And this is grade 3. We can see there's some mobility in their back leg, but without any support, the dog just sit there and not move. And this is grade 4, where a dog is not really moving much in their back end, like there's effectively zero movement that we can see or we can feel. And up to grade 5, where you usually have to test about how much they can feel in the back leg by pinching their toes, and they're not looking at you. So I found this very helpful because without visualization, sometimes it's kind of like hard to understand what a walking means, and those kind of will give you the impact, the impression of how much what we're expecting to qualify as a walking dog. So I found this to be most helpful, and these numbers are really helpful to make a clinical decision based on the time of how the clinical sign present on its own. And also the other thing is personal experience to share. These are kind of like a sliding scale. We don't always have to stick into one endpoint at a certain time. I've definitely seen dogs that have presented as a walking but wobbly back legs, and then 2, 3 days later presented back to me again because the dog is totally paralyzed and but maintain pain sensations. Or I have also had dog that comes in as a non-ambulatory paraparesis dog, and then 2 days later is starting to get up and walk. So it's always good to kind of remember these grading system, and so that you can make the most informed decision at any given times in terms of what should I do and what should I expect. The next one, they will talk into more details about the component of medical management, duration exercise restrictions, which is another topic, so I will pause here. But I really recommend that when you come into clinic or when we have a discussion about disc herniation, these are usually a fairly accurate numbers to remember and share and help you make a clinical decisions.